How many of you have heard of about PTAB? Okay, just a couple. All right. Okay. So I mean, so Dr. Bhaskar showed us, incredible amount of work being put in. But as so some of these cases are just not going to do well because of their high restenosis rates, and sometimes you've exhausted all different types of approaches to keeping the vessel open. So the gold standard has always been a fem-pop bypass with above knee using a vein. But unfortunately, because of a lot of reasons, including coronary artery disease, bypass surgery, venous ablations, sometimes adequate veins are not available. So therefore, there was a percutaneous approach that was thought of and developed by Jim Joy. So again, this is like kind of a classic example. I'm just going to start with the history. A 73-year-old gentleman, lifetime limiting claudication, progressive ischemic rest pain, had multiple interventions of his ISR CTO for his right SFA. Obviously, has a cabbage. He's a former smoker, and again, he has a horrible ABIs and a complete limitation of his activity. So arterial duplex shows there the occluded stent, as you would think, all the way down, and obviously there's a reason for his symptoms. So when you do the diagnostic peripheral angiogram, you can see here is an ostial occlusion of his SFA. He has distal reconstitution at the level of his above knee pop, or just a ductal canal, maybe P1, P2 segment, and then he's got 3-vessel or 2-vessel runoff to the foot. So usually in this, your algorithm should always be the following. Well, first, how symptomatic is he or she? Well, generally speaking, always medical therapy is the most important thing that you do, and sometimes it's very difficult, I'll be honest with you. You talk to patients who are symptomatic and tell them to walk. It's kind of, almost a misnomer to say, hi, I'm having pain when I'm walking and you want me to walk further, but that has been proven in studies along with cilostazol, as you would have heard from Daniela, that it helps. So that's got to be part of it. Then, just since it's an interventional fellows course, you want to think about the different approaches, right? So you've got laser with DCB, followed by DCB, followed by intervention with Rotarex and DCB. Maybe you want to reline it with a Viabond and do sort of a percutaneous bypass without actually within the stent itself. And then, of course, PTFE bypass or jet stream. So when you look at the data, and I don't want to spend a lot of time here, so you have to know certain data as an endovascular specialist. Obviously, all of you are here to learn about this, but it's also important that you put in the effort to go and understand, because when you're this is the only field in cardiology where you're working with 3 different specialties. 4. You're working with vascular medicine, vascular surgery, interventional radiology, and of course, interventional cardiology. So you've got 4 specialties involved in this, and you need to be able to speak the lingo and the data as well as they do. So obviously, Excite ISR was done. I don't know how many of you have heard of Excite ISR. Okay, very few. So if you're in an endovascular fellows course, you need to know this. So this looked at laser versus balloon angioplasty for in-stent restenosis. And again, you can see the data here, and I'm just going to, for the sake of time, keep going. The other thing is also DCB. All of you have heard about DCB, but DCB has been used in ISR, and it's in the IMPACT Global Registry, and there's only TLR data out to 1 year. So, I mean, DCB is an effective therapy. Third is Reline. Reline is the randomized controlled trial looking at balloon angioplasty versus covered stenting for in-stent restenosis or complex long lesions. So you can see here it was 79% or 80% for endoprosthesis versus 42% for PTA on 12 months. JET ISR, Bhaskar was part of it. It was 79.3% and 60.7% at 1 year, with the jet stream followed by balloon angioplasty. So PTFE bypass is another alternative. As I said, veins aren't always available. So when veins aren't always available, the PTFE bypass was used. So when you looked at PTFE bypass, you have a 12-month patency reported between 76 and 85%. But it depends on where you anastomose. If you anastomose the bypass above knee, it's a lot better than it is below the knee. So when you have options such as this, you need to understand what are the patency rates in which you are going ahead and giving the patient the option. Rotarex, again, how many of you have used Rotarex, have heard of Rotarex? Okay, very few. So there'll be a Rotarex workshop, a breakout for you with BD, so please learn about it. It's actually probably now the gold standard in atherectomy for ISR, along with Jetstream. And again, it showed a 12-month, primary patency of 86.2% and CDTL rated of 89.7% using Rotarex with DCB. But why I'm here to talk to you is the detour system. So as you can see, our results aren't the best, and a lot of times with these complex lesions, you're going to have embolization, you're going to have restenosis, and so on and so forth with this thrombus. So with the detour system, you're doing a percutaneous bypass. So you can see here, so this video that's playing, you see this long segment SFA occlusion that's all the way down. You can see it's a calcified lesion, and it's generally in the study, it was about 20 centimeter lesions that were utilized. And you can see here, and you have this system called this is the torus stent graft along with this dynamic, needle, which is again very, very powerful. So the needle reentry along with the torus stent graft system is what's used in the detour. And what you do is you get ipsilateral venous access, meaning the leg of concern, you're going to get a venous access, usually in the posterior tibial vein. Then you're going to go ahead and put a snare up into the common femoral or wherever you want to re-enter and create the fistula from the artery into the vein. So there's your snare. Then you're going to come down with this endocross device, which is a very, very powerful needle. It ain't no Outback, for lack of a better word. And then when you shoot this endocross, the endocross is going to go ahead and create a fistula, and then the wire is going to be crossed, and then you're going to snare the wire into the vein, and then pull the wire down. Then you're going to walk out the endocross, and then you're going to create your fistula, generally using a 4 or 5 millimeter balloon. And then once the fistula is created, right there, you're going to create the fistula with the balloon, and this is where the patient usually feels a little bit of pain. And then once that's done, you're going to go ahead and reintroduce the endocross through the fistula. So the endocross gets pulled down through the fistula, because now remember, you have a through and through wire from the artery into the vein coming out the foot. Now you're going to go to the distal reconstitution zone with the endocross. Again, it's a technique of lining it up properly, and you can learn that. And then you go ahead and shoot the needle again, and then you recanalize into the distal and basically create a bypass through the vein. Then at this stage, you go ahead and internalize your wire. So now you've got a wire above and a wire below from the artery into the vein and then back into the artery. Then you go ahead and balloon the distal anastomosis, again with the balloon, and then you place your stent grafts into the vein. So obviously, this is actually a very easy procedure to do, truthfully, and very safe. And generally embolization rates are 0, and so on and so forth. So I think I'll show you the data in a second. So in order to do this procedure, you need to evaluate the leg with a CT. So you go ahead and get a CT and get the common femoral diameter and the diameter of the pop to be able to size your stent grafts. And then here you can see you're measuring your diameters here. And then you also want to get the proximal landing zone and the distal landing zone. And then you want to go ahead and look at the veins and then measure the veins. So you remember, you have to have at least a vein that's greater than 10 millimeters. Generally, we like to prefer 11 millimeters or so. And I think it's important to be able to have that size in the vein to allow for good flow. DVT rates are low, and I'll show that to you in a second. So again, you have a case and plan, and these are the sheets. So anyway, so what's the clinical data? So the Detour 2 clinical data showed primary patency of up to 2 years, up to 69.1%, very comparable to PTFE grafts. 81.8% at 1 year, which is obviously better than PTFE grafts. And again, you can see the historical stuff that in the PTFE clearly shows that this is as good without the morbidities associated with percutaneous bypass. As you know, with percutaneous bypass, you can have MIs, you can have wound infections, so on and so forth. Again, TLR rates were excellent at 76.7% at 2 years. And then symptomatic DVT or even DVT. All DVT was at 1 year with 4.1%, but pulmonary embolism was 0. And at 2 years, it did not increase to greater than 4.1%. So obviously, it remained stable after 1 year and did not increase. Major amputation in the trial was amputation-free survival was 98.5%. So in conclusion, the Detour system creates a percutaneous bypass for complex femoral popliteal lesions. It's an easy procedure to do, high procedural success. You've got a high safety and efficacy achieved as compared to PTFE, so very similar to PTFE. If you have a vein and the patient is a candidate for a vein bypass, absolutely the vein, I think, should precede anything we do percutaneously, and especially a Detour bypass. The venous thrombosis is a concern. 4.1% is not a small number. Excuse me. But it stabilizes, and does not increase after 2 years, and there was zero pulmonary embolism rates. So therefore, it is really a good device to use, at least in our books, in a patient who has a high rate of restenosis with multiple failures who's not a candidate for surgery. So let me show you a real live case that we did. So here you can see we got a high popliteal axis here. I showed maybe a high posterior tibia. It looks like more like a pop here. And then you can see we did a venogram, and then you could see up top here, we went ahead and you had to create a 4 centimeter distance between the common femoral and things. So this guy had 5-6 ISR interventions, so we said, let's go ahead and do the percutaneous bypass. We went and fired the needle, snared the vessel there, as you can see, snared the wire, and then in this slide, externalized the wire, and then at the level of the pop, went ahead and fired the needle, and then went ahead and entered into the vessel. And you can see it right there, right into the vessel. So here we're creating the fistula here, but below and above through the stent, you could see it's no problem. You rupture the balloon a few times, but you're able to do it. And then we went ahead and lined the endocross all the way down and all the way up into the common femoral. Okay. And then, let's see, did I go backwards? I probably did, didn't I? Yes. How do I go forward? I'm going backwards. There you go. Sorry, guys. Okay. So then post-intervention angiogram, you could see here's your bypass. You exclude the stent, and nicely the bypass has been done. You could see this kink is nothing major, and then you could see here you maintain your runoff to the foot all the way down. And so I guess the questions that we're going to have for discussion is, how does PTAB fit into your algorithm in these complex cases? What are the differences in surveillance going to be with PTAB? Your difference in anticoagulation or antithrombotic therapy or antiplatelet therapy, and of course, which is the right patient for PTAB, and how many interventions are you going to do before you go ahead and perform a PTAB on your patients? So as you can see, I think there's a lecture on DVA. No, PTAB, is there a lecture on DVA? I'm not sure, but there's tomorrow. Oh, in the session. So as you know, that there's always increasing technology, and we're trying to show a good efficacy as compared to surgical bypass in this. And I think this is an important skill that all of you need to learn if you're going to be endovascular interventionalists. First and most important thing I really want to stress to all of you is, I know it's very sexy to do endovascular intervention, but remember, you need to know the data. You need to understand the data. You need to understand that there's multiple specialties playing in the field that you're playing in. So you need to make sure that you're providing the most optimum care for your patients by understanding across specialties what's available to take care of your patients. I thank you for your time.